So let's look at some treatment of specific conditions that the patient might be experiencing. So pulmonary edema, like we said, that could be coming from congestive heart failure. So we're hearing rails here. We would want to provide 100% oxygen, potentially suction, depending on how severe it is. If the patient is coughing up a lot of sputum, especially if it's pink frothy sputum, we want to be really concerned and begin suctioning. We want to position the patient as comfortably as possible, and if your protocol allows, then we want to administer CPAP to the patient. And so CPAP, remember, that is continuous positive airway pressure, and so that's going to be where we are putting the mask on the patient's face. It's delivering forceful amounts of oxygen to help blow those alveoli open and to push some of that fluid back out into the interstitial spaces. We want to consider ALS intervention here, and then also transport promptly. With chronic obstructive pulmonary disease, or COPD, we want to administer not necessarily a prescribed inhaler, but we could give a nebulizer treatment if the patient had previously been prescribed. And if not, we would want to consider calling medical control for permission to administer if they met the criteria with the severe dyspnea and wheezing. We also want to consider CPAP here as well. This can be used for both moving the fluid out of the alveoli, but also opening alveoli that are collapsed. And so it can be used in really severe cases for both of these situations. So again, positioning the patient as comfortably as possible and transporting promptly are going to be our best options. We could also consider ALS if we needed them as well, if the patient was not responsive to treatment. With hay fever, there's really not a lot that we can do, and it would be unlikely that they need emergency treatment. With asthma, as we said, they really are going to need some bronchodilators here, so nebulizer treatments. If they're not responding to nebulizer treatments, or they've already used a lot of their own at home, we would want to go ahead and call ALS so that they could provide other treatments that they have in their toolbox. And then anaphylaxis, remember, as we said, that's the EMT's bread and butter. So there's a lot that can be done here. Epinephrine is going to be what makes the difference and actually saves the patient's life. But then we also want to consider administration of those neb treatments, and also our Benadryl as well if the patient can swallow. If they've got really swollen airway and swallowing is not ideal right now, then we want to call for ALS assistance. They would be able to give that Benadryl as an injection. With the spontaneous pneumothorax at the EMT level, all that we need to do is provide supplemental oxygen and treat the patient as best we can. We would want to go ahead and call ALS because they could do that needle chest decompression, but rapid transport and careful monitoring is really the best that we can do. With pleural effusion, that fluid removal's got to be done at the hospital, so providing oxygen, allowing them to sit in a position of comfort, and rapid transport is our only method of treatment there. We talked about what to do with the airway obstructions as far as partial and complete obstructions, so I won't go over all of that again. We talked about that in the previous video. With pulmonary embolism, looking at supplemental oxygen, position of comfort. If they have hemoptysis, which is coughing up blood, then we want to make sure the airway remains clear and transport the patient promptly. At the hospital, it will depend on the size of the clot and the hospital's capabilities as to whether they are able to go in and actually remove the clot, whether they're able to give clot busting medications, or whether they're going to be on long-term blood thinners. Hyperventilation, we want to kind of determine the cause of the hyperventilation. Is this anxiety related, or is it coming from like a metabolic issue? We want to try to coach their breathing down, and while we never want to utilize a paper bag itself, we can do what is called a paper bag effect, which would be having the person put on a non-rebreather mask, but instead of hooking that up to oxygen, we actually have them breathe into it, and so their CO2 is going to be going into that reservoir bag, and they would be breathing it back in, but also having access to some oxygen as well through the vented holes on that non-rebreather. So that's a safer method there. If they are having a lot of difficulty breathing, we could consider oxygen, but with it, again, it's depending on the cause here. If they're gasping for air and that's why they're hyperventilating, then oxygen might be best. If this is anxiety related, then it's not going to help because they already have so much oxygen and not enough CO2 that really what they need is more CO2, and that's why that non-rebreather mask might be more effective and help stop some of those numbness, tingling, and spasming in the hands and feet. Look at the environmental or industrial exposures here. We want to make sure that the patients are decontaminated so that they're not further risk to themselves and risk to us in a small enclosed space. We want to treat them with oxygen, potentially airway adjuncts or suctions based off of how they are presenting and what type of airway management they need, but not a lot that we can do in the field. If there's foreign body aspiration, so blood, vomit, secretions, we want to clear the airway with suctioning, and we can also provide oxygen and transport as well. If the patient has had a tracheostomy and that begins to dysfunction, so remember they have that opening in the throat directly into the trachea, whether this is just a hole as the stoma or whether there is an actual tube there. Usually what happens is this becomes clogged with mucus. That's pretty common. And so at the EMT level, suctioning, deep suctioning of the trachea is not an EMT skill. All right, so note that. While they do need to be suctioned, it is not in the state of North Carolina an EMT skill. So we would need to contact ALS for that if we saw that the patient needed to be suctioned. But we could provide oxygen. Remember, we want to do so over top of that tracheostomy or stoma because that's how they breathe. So never over the mouth and nose. With asthma, we want to provide oxygen here and also use of the meter dose inhaler if the patient has not used their own, if they have it handy and it's an emergency situation. But we could also, again, if they've been prescribed, utilize our own nebulizer treatments of albuterol or Xopenex, depending on what you have on hand and what the patient has previously been prescribed. And then with cystic fibrosis, this is a genetic disorder that affects the lungs and the digestive system where you have an overproduction of mucus, and ultimately the patient probably is going to be on home oxygen on their own, and this could progress up to the point where they would actually need a lung transplant. So if this, the mucus is an issue, again, if it's starting to come out, then we could suction in the mouth or nose. But if this is deep suctioning, again, we're going to need ALS personnel to do that. That's not something that we should be doing at the EMT level, but we can provide some oxygen. So that's going to be it for the respiratory chapter. Hopefully this has been really informative to you guys. And as always, if you have any questions about any of the specific material that I covered, please don't hesitate to reach out and let me know if you have any questions.